what we'd like to do is really talk about payment and delivery reform to you. As Rufus said, there is a dynamic going on right now, and there's a paradigm shift. We're focused on outcomes-based kind of reimbursement. And as Dr. Nichols said earlier, it's going to take a monumental, though collaborative approach to actually get this accomplished. You're going to hear from my colleagues all the efforts that they're doing, from a provider standpoint. I'm going to give you a little perspective of what we're doing from a payer standpoint, representing a lot of large employers. But it's going to take a lot of membership, a lot of volume in the physician practices and so forth to actually get this accomplished. To work in a bifurcated model, it's going to be very tough to continue to operate the way we do today and expect to have some type of outcomes-based reimbursement that would be beneficial to everyone. So what's going on today? I don't think I have to really talk much about the perverse incentives. We basically pay fee for service, and then we try to measure quality underneath it without really giving the physicians and providers what the report card really needs to be. And, we talked a little bit about trying to standardize the quality measures. The problem is that, at least in the electronic and technology world, they've done a really good job. Like if you're from a financial standpoint, you have the ASCII standards and so forth. And they've established what those kind of common elements and methodologies are going to be. The problem is right now is that we're running a beta. We have CDs. We have VHS. Nobody's really defined what those quality measures really need to be for all of us to be measured against so that we can really start shifting to a more value-based reimbursement. On top of that, since we are working under a fee-for-service kind of model, what we are doing is putting other kind of edits, utilization edits, and other kind of bundlers and group edits and claims processing edits to make sure that we're paying claims appropriately. But at the same time, we're demanding that we get the high quality as well as trying to get the diagnosis on the claims for other clinical measurements such as HEDIS and so forth. There needs to be a shift from today from a episodic kind of care-based system to more of a continuum. We got to look at the entire continuum of care instead of each patient being treated. And that's going to mean a more collaborative alignment of resources around payer information, including what the health plans have, as well as other insurers and payers such as the government and so forth, as well as information from us, so that we can now focus on populations instead of individuals. What's driving this? Forums like today are driving this. This is representing some of the commercial market, as the Honorable Tavener said, that CMS is also starting to drive some of the quality outcomes-based incentives. But there are other things like the large employers. There is a session going on, a concurrent session going on right now, and they're talking about how to engage another important stakeholder, which is the member. But basically, employers are looking for more of a quality outcomes-based model. That it's not acceptable anymore to have trends in the double digits going forward, that somehow, some way, we've got to improve the quality and come out with a much better cost model. On top of that, what we're starting to see is a movement by the provider systems into more of a clinically integrated network or an accountable care organization where they're able to take on not only the quality perspective of it, but an additional risk. So I talked earlier about what's this going to take in terms of an alignment or a collaboration between stakeholders for resources and information. And from the payer, and as Dr. Nichols said, large employers, you guys own the data, And when it comes into the small market, the insurers have the data, for you on your behalf. And so what we need to do is kind of meld what we're calling utilization and claims data that we get from a payer perspective and be able to deliver it on a real-time, actionable basis to the delivery system. And I won't go painfully through each one of those, but you can see the different buckets of information and some of the other strategies that we're going to have to do. This really needs to be put into a clinical performance measurement system, which is a way to aggregate the clinical and utilization data along with the financial targets so that the providers have actionable data at the time of care. From a payer perspective, what we're starting to see is two different kind of options that are out there. A lot of you probably have heard about high-performing networks. And over time, each one of the networks that you're going to hear about today are going to strive to be a very high-performing network. And hopefully, they'll be all-inclusive, that all providers will get on board once they understand the data set and how they're going to be measured. And basically, we'll just move the entire bell curve, to the right and have a much better quality product. But in the interim, you're going to see what we're going to show as select networks. A select network would basically be a incentive-based network, either at a premium through the employer, or it could be through a contribution, kind of model where they steer by choice at the time of enrollment, whether or not you're going to pick that exclusive network. Or you could have a tiered network where it's a subset of a much larger network, and you might tier at the time of service by copay or other type of co-sharing concept. And last, since I am in the sales and marketing, if I didn't mention why Optima, I probably wouldn't have my job. So basically, Optima Health is statewide. What we do is we offer various products, both on the government standpoint, Medicaid and Medicare, as well as commercial products, group, employer-based, as well as individual-based. So we have a very good understanding of the diverse portfolio. We're also owned by Centera Health System. It gives us a good appreciation of the delivery system, and we make sure that we are focused what we call productive tension between the health system as well as the insurer. We believe that healthcare is regional, and we're working real hard, especially with our colleagues here, to try to put together models that we can then offer to payers like yourself and so forth, so that they fit the strategies of each one of the organizations. We're currently operational. We have a kind of an incubator with our own employees. Centera employs 30,000 employees. We're going to be going live with our own clinical integrated network on January 1st with 18,000 employees going through that model. And we'll be actually then benchmarking the outcomes of those off of 7 to 11 different quality measures and hopefully be able to report those back out to you. And the last thing is that we try to be collaborative and nimble, being a regional plan, and knowing that we have to get this to work inside of the state here. We're real receptive to different models of delivery and care.